Hello all, Dr. Derek McClister here. We're going to be doing a presentation on the deltoid ligament in review. So hopefully I can highlight a little bit about the anatomy, some imaging, some studies on this and why it's so important, and then highlight how we do things to treat it, whether it be acute or chronic, and ultimately treat our patients better because of this. The goals, we're going to go through an introduction, anatomy, functions, mechanisms of injury, imaging, acute and chronic injuries, and the literature associated with those and treatment of it, and then my concluding thought.
All right, guys. Overall, ankle injuries are one of the most common reasons people go to the urgent care or ER. In general, about 5 to 16% of these sprains are medial ankle sprains. So we have to be diligent about these. They're not all just lateral ankle sprains. Rigby came out in 2024 and described 40 out of 226 chronic ankle instabilities have medial ankle issues that he ultimately ended up fixing. So that's about 17%. So that's kind of equal to the number of incidents that we're seeing in the ER visits. So just be paying attention that medial ankle injuries are very common, and they can be part of complex ankle injuries or part of complex ankle instability. Once again, we've usually been focusing on the lateral ankle ligaments, but there's been growing awareness of the medial osteoligamentous functions, such as anatomy, which we'll explore here in a little bit. And then we kind of continue with this. There's still controversies in treatment, whether it be acute or reconstruction. Overall, anatomy-wise, we've been becoming more and more diligent about knowing anatomy, how to fix these things. So it's really important that the next couple of slides will show the anatomic studies. But in general, we've been taught that there's been two layers, superficial and deep. The superficial crosses two joints, roughly has 4 bands, what we've really learned. The deep layer crosses one joint and has 2 bands. This is kind of a medial ankle picture. Lots of anatomy in this, so don't dive too much into it. But number 3 is really important. And then obviously over top of that is really important for the deep and superficial. I think these do help define our function, and there's no consensus, but I feel like we're getting closer.
JBJS produced this really good study, and it was in 2014 as a cadaveric study, so 14 fresh specimens. They really dissected the medial ligaments, and they have really good pictures that you'll see here. And I really love this study. This was early on when I was in residency. I really focused on learning from this study, and it helped me almost teach myself, teach my colleagues, and as residents and students, and then ultimately I presented this to my attendings as well. These are the great pictures that I'm talking about. They had really great defined and dissected ligaments, and so I really like this study. And this is another picture from that study as well. That's more the deep. The top are the superficial. The bottom is the deep. And this is good description of where they're attaching and how they attach. The results of this study, the superficial band has the tibio-navicular, which is found 100% of the time. They had the tibio-spring, which was 100% of the time. And then they had the tibio-calcaneal, which they found 79% of the time. And then they have the superficial portion, which they found 79% of the time as well. The deep was more consistent. The deep anterior, about 93% of the time. And then the deep posterior, they found 100% of the time in these specimens. Adding on to this, a more meta-analysis anatomic study was done in Foot and Ankle Specialist in 2016, so shortly after this. They weighed values of prevalence, size, and attachments and surface area, and they really went through all of the literature regarding this. And what they found was this meta-analysis of the cadaver studies was very consistent with the JBJS study. They found that the deep portion was there about 100% of the time. They found that tibio-navicular was there about 90% of the time, and then the tibio-calcaneal about 85% of the time. So in a large is that we know the deep is going to be there pretty much every single time, and then the differences in anatomy, and everybody's anatomy is a little bit differently, as we know just through doing surgery and dissections, that the superficial band is a little bit more variable. The overall function, I think this really kind of plays in how and why you're going to maybe fix things, but the talus is a 3D motion that it goes through plantar flexion, dorsiflexion, eversion, inversion. So you have to know that it provides peritalar stability. This is kind of a good picture of what the talus is doing depending on if you're supinating versus pronating, and how it may affect the deltoid ligament or just the ankle ligaments in general. And then here, the planes of motion and how that may affect where your foot position is and how you injure it. Overall, I like to say the superficial, based on studies, show it resists valgus or eversion at the arc of motion. So superficial is more valgus motion, and it tries to resist that. The deep resists external rotation and lateral translation, which I think we kind of understand from ankle fractures that might be consistent with what we see. Overall mechanism of injury, I always just like to say, think of it very simply, is that pronation usually causes more medial ankle injuries than supination. Supination usually causes lateral ankle injuries. And I think if you went through Log Hansen, you could kind of break those down and see if it starts with pronation, it's usually medial, which means there's going to be a medial type injury, whether it be a fracture or a ligamentous injury. And if your supination usually starts laterally, and you usually have a lateral ankle injury, whether it be fracture or ligamentous injury. Diagnosis, so everybody diagnoses these a little bit differently, but I think overall we can kind of get through this and try to be as simple as possible. Physical exam, I think really you just have to highlight and have suspicion. A good study, Steenquist et al., positive predictive value of about 80%. Medial tendinous can be useful in tweeners. So if you're questioning whether they have a medial ankle injury, if you palpate medially and they have pain, it might help you determine that this is a more severe injury than if they didn't. Now, you don't rely on this alone. You can't just say, oh, you got a positive medial ankle pain after an ankle injury, you have a deltoid issue. Maybe you need to wait a couple weeks to really kind of define that. And similar studies in 2004 have found the similar things, is that maybe medial tenderness is indicative of a medial injury, but it's not predictive 100% of a medial injury. X-ray, I always get initial evaluations. That's our first thing that we'll want to do. MRI, I think, is great. It's useful. I don't know if I use it all the time in acute injuries, because if you have a bad ankle sprain, I'm not running to get MRI because it doesn't help me do surgery immediately unless I'm worried about a high-level athlete. I do think it helps us to find more chronic injuries. So after you do 6 weeks, 3 months of physical therapy and rehabbing, and if you're just not getting better, why? I think that's when we'd get an MRI. And then obviously for us as foot and ankle surgeons, thinking about this in a way that is really about chronicity and ankle valgus from a flat foot, or long term, I had an ankle injury many years ago and my foot's become flat, or my ankle gives out, or I have bony spurring there, that you maybe had an ankle injury and an MRI could help us. Ultrasound, in my personal opinion, I don't use very often, and in literature there's really no specific evidence of this being super useful. CT, I think good for bony alignment of the ankle and syndesmosis. Obviously, if anybody follows me, I love weight-bearing CT scans. And why I love weight-bearing CT scans, I think will be shown later on, and how the deltoid and the syndesmosis all play a role in each other. But ultimately, weight-bearing CT scans gives you the loading of the foot and what it's doing with the ankle at the same time. If we're going to get into x-rays, I'm going to highlight that I use gravity stress quite often to help me define whether there's a medial or acute ligamentous injury. Lots of good studies, 2016. if you do a gravity stress versus the normal population, and basically normal is about 3.6. Usually it's not greater than about 5.2 on the normal population. 2017, the level of evidence I didn't really get. It didn't really break it down. But it does not matter from this study whether you have an implantar flexion, neutral. The larger the cutoff is for medial clear space widening. Basically, if you have increase in medial clear space widening, you're going to really suspect an injury. Another one in 2007, it's the level 1. It's the highest level that we can reproduce, but gravity stress is equivalent to manual stress. So acutely, if the patient comes in with an isolated fibular fracture and I'm questioning whether I need to fix it, which I fix quite often, a lot of isolated fibular fractures because I don't want them to go to post-traumatic arthritis down the road, especially in younger patients, I definitely just get a gravity stress. And most of the time, it's giving me that 4 or 5 medial clear space, and in my opinion, I'm just going to fix those so I can reduce the chances of issues coming up down the road. Let's continue with stress radiographs. Another good study in 2015, basically kind of highlighting what I talked about earlier, level evidence of 2, medial clear space widening of greater than 5 is really specific in helping really determine that, hey, you probably need to really suspect a medial injury and maximizes your sensitivity and specificity of an external rotation stress exam. So going back hand in hand is that gravity stress is a great example of it. Another good study here, 2017, level 3, weight-bearing radiographs are reliable method to assess stability. They found maybe gravity stress overestimates instability. Again, if I had a question on this, I'm going to probably get a weight-bearing CT scan of the contralateral limb and probably contralateral x-rays just to compare. So I'm not personally worried about this, but I do get weight-bearing x-rays if they can stand on it. I do get stress x-rays, so gravity stress. And then if there's still concerns, I'm going to get a weight-bearing CT scan and probably just advise fixing it so I don't have to worry about it down the road, or the patient will have to worry about it down the road. But overall, there's lots of studies out there talking about how we assess a deltoid injury, whether in the acute setting or chronic setting, and this is more acute. What does gravity stress look like? That's an example of a gravity stress exam where you'd have the x-ray now, then taking that x-ray, and the fibula is allowing translation and giving us that picture. So the talus should translate and opening up the medial clear space if it is unstable. That's an example of an external rotation exam. And again, both of these can be done with good quality of evidence.
Overall, I think arthroscopy plays a huge role. There is people that debate whether arthroscopy is important for medial ligamentous injuries in general, whether it be ankle fractures or chronic ankle instability. Schuberth et al. Kind of led the way, in my opinion, back in 2004, JFAST level 4 evidence, but I think this is really just a home run paper that everybody should know. If you have greater than 5 millimeters of medial clear space widening, they found through arthroscopy about 74% of those showed some type of medial ankle injury or deltoid injury. Greater than 6 widening showed 93% of injury or some type of or deltoid injury, I think for me, this is the biggest point of these papers is 5 out of 5 pronation, external rotation, level 4. So medial ankle injuries occurred with that type of severe injury. And similar to that, 6 out of 4 or 6 out of 7, SER4 injuries had deltoid injuries or deltoid tears. And so you have to have this high clinical suspicion if it's a really bad PER4 injury, SER4, or just a higher level PER3, SER3 injury, that you have to have diligent about remembering that the deltoid is likely injured. Knowing that log Hansen's really helps you get through this. Another good study in 2020, level 3 level of evidence, found out of medial clear space greater than 5.5 usually had a deep deltoid injury, and that was complete. Medial clear space less than 5 millimeters had usually partial deltoid injury. So again, that 5 millimeters is, in my opinion, that really number that we want to look at. So if there's any question, whether it be like 4.5, 5, you just have to suspect that there's a deltoid injury. Gonzalez et al. Did a systematic review in 2016. They really found insufficient evidence that it affected outcomes with ORAF. I think we'll prove some of that to be maybe anecdotal because we don't have the right classification. We don't have the same treatment. We all don't treat everything exactly the same, so it's hard to say exactly from all those studies, but it does show that there's fair to good evidence for diagnostic utility to use arthroscopy through acute ankle injuries, such as ankle fractures. A good study, arthroscopy 2016, level 4 level evidence. It says accurately diagnosing and managing syndesmotic and deltoid ligament injuries, you can use arthroscopy. And then what they kind of talked about back at this time, which I think is ahead of its game, and I think Rigby has really helped define this over the last few years for studies in 2022 and 2024, and I think 2026, about the medial drive-through sign. But they really found that if after you fix an ankle fracture and you put a scope in and you try to go through the medial gutter, and if you can't get through it, there's likely not a ligamentous injury. However, if you're able to put a scope in there and stick it through, and you feel like there's a drive-through sign, whether you did a syndesmotic repair or not, in my opinion, that you should likely either consider doing a syndesmotic repair, which I would do first, and then I would go back and re-stress it and then fix the deltoid if there is still continued instability. But this drive-through sign, that medial drive-through sign, which he was starting to use through the syndesmosis, if you're able to push it through the syndesmosis, that just laterally really helps define this as well. But I think this study kind of gave us that medial drive-through sign that Rigby has really highlighted lately. So arthroscopy is a very big tool, whether it be diagnostic or just an indicator that if you have medial clear space widening, that we really should be suspicious of it and don't hesitate to put a scope in there.
Going into arthroscopy, there's some good studies about doing arthroscopy and sectioning. Here's some more cadaver studies about this. 2018 arthroscopic exam, they used pronation, external rotation injuries, and then they did sequential cuts, and then they did arthroscopic views, and then they did some specific testing. They concluded that you have to have multiple ligaments injured. So the deltoid plus anterior inferior tib fib ligament or the interosseous equals instability. If you just have two, you're probably not going to have major instability, and maybe that doesn't mean that you need to fix it. But again, who wants to take that risk? I'm going to fix my patients no matter what if I have any concerns for instability, just because we know the devastating facts. If you develop an injury or chronic injuries and you keep on repeating these injuries, that you're likely going to have either tendon issues, joint issues that are compensating. So good studies showing that you have to have multiple ligaments injured, whether it be fractures or ligaments injured to reproduce this. Going back to Log Hanson's once again from a student standpoint, no Log Hanson, because it helps you define injuries. Continuing with arthroscopic evaluations, they did sequential cuts back in 2020. Then they also did sagittal plane stressing. Syndesmotic instability occurs in sagittal plane, and it all includes 3 ligamentous injuries. With partial injuries, you have to have the deltoid injured. And they described this fibular test where you're pushing it anterior and posterior. And they said if you have more than 2 millimeters of motion in the sagittal plane, that you're going to have some instability there. Back in the guy that we just talked about in 2018, he produced a 2017 study. Again, very, very similar studies to this. So he's done 2 different ones now. Anterior and posterior instability noted if you've injured all 3 syndesmotic ligaments. and then anterior only with a deltoid ligament. So again, highlighting that the ankle is complex, it's peritalar stability, and ultimately you have to have multiple ligaments injured or multiple bones injured on the medial and lateral side to be consistent with a deltoid injury and suspicion of it. Other than doing imaging, arthroscopy, what's the MRI show us? This study is not so much telling us anything specific, but it's an anatomy study. I'm going to go through some pictures of it really well. So they wanted to define those ligaments based on MRI. And this is just a great study highlighting what it looks like from an MR standpoint, what you're looking at, because I think we all get a little bit confused on an MRI sometimes what we're looking at, especially in injury states and not just normal healthy states. But I think this study back in 2016 really helps us define that and get a better view of what the deltoid looks like and what the medial ligaments look like, whether it be the spring tendons in that area as well. Again, highlighting this, tibial navicular, tibial spring ligaments, and all above. Really good imaging. So I really highly suggest you look at this study. Radiographic identification. I think we all have to know where to place anchors, where to know to repair things, to know where our normal anatomy is. So Clanton, EDL, again, just did a great study. They have one very similar on the lateral ankle complex. So 2015 cadaver study, they dissected them out. And again, hard to see. I don't want to belittle this, but you should just go take a look because that goes hand in hand with the MRI study, where these ligaments are. And what they found through this cadaver study, that the superficial bands include the tibial navicular 100% of the time, tibial spring 100% of the time, TC and SP 75% of the time, and the deep bands, once again, basically 100% of the time you're going to find them. That anterior band is a little bit mixed. I think that correlates with finding the superficial ones and why they're there 100% of the time, because sometimes maybe they blend together. Acute injuries. So we just kind of talked about ankle fractures, log Hansen's, but this is how I usually define it. Ankle injuries, and what this means, basically reported over 100 ankles, or over a series of 300 ankles. Incidence of post-traumatic arthritis was 14%. They correlated with fracture patterns and injuries. And so basically a Weber B, if you have a Weber B injury, you're going to get 12% that you might likely get arthritis from this. A type C Weber B injury, which again is higher level of injury, you're going to get maybe a possible 33% from this series of ankles. Clark colleagues, 6 millimeters of displacement of the fibula caused no decrease in contact area. Sectioning of the deltoid contact decreased about 20%. So we know that medial clear space, if it's widened, that's definitely going to affect things. I'm not certain that I believe 100% in this study, but it tells me again that I have to have suspicion. Medial clear space widening tells me suspicion, and then if I have suspicion, just go fix it so we decrease that chance of post-traumatic arthritis. Curtis and colleagues, they found 30% decrease in tibio-talar contact area, 30 degrees of external rotation, and 2 millimeters of fibular shortening. If you add the deltoid sectioning, everything goes up to 60%. Again, the deltoid plays a significant role in peritalar stability, which means the ankle and foot combined will have issues if the deltoid is injured. Sprains, medial injuries that turn into instability. So those chronic injuries, or even a flatter foot that just never, it gets neglected. It's not supported with insoles, braces, can have this chronic issues. But in specific, there's 3 grades of injury. And Hinterman really classified this. Again, Does it tell you a lot? No, it just tells you, hey, students, there's 3 injuries if someone pimps you on this. Residents, if someone pimps you on this. Know that there's been 3 defined grades of injuries by Hinterman. All 3, they say, can be treated conservatively. What I look for valgus tilt, asymmetric collapse, and then I would just get stress imaging if I had any concerns. And then obviously, like I talked about, I'd get an MRI. But stress would really maybe tell me that maybe I should go and get a scope in there, clean it out, and then do a medial brostrum if needed. Ankle fractures and the deltoid continued. There's controversy. There's limited literature with high quality evidence. So a lot of it's anecdotal. Hey, I do this. Hey, I do this. The definition of instability and recognition. So how do some providers define instability? And then how do they recognize it and fix it? And then everybody fixes the syndesmosis a little bit differently. So what does the evidence tell us? Foot and Ankle International 2018, level 3, they did ORIF with deltoid repair versus without deltoid repair. They found that clinical outcomes were really not significantly different because they did the ORIF. However, the repair group had maintained a medial clear space widening better than the non-repaired group. And then with a syndesmotic injury and a medial clear space, if they had a syndesmotic injury that they fixed, they found that the medial clear space was better if they repaired with the deltoid. So, hey, I did a syndesmotic injury, repaired it, and then I fixed the deltoid with that. They had better outcomes than if they just left it. So again, telling me that there is something to fixing the deltoid in certain populations or certain injuries. And I believe this goes back to Schuberth, showing that PER4 injuries and SER4 injuries have ligamentous injuries. So why not go back and at least fix those so we have less chronic issues down the road? Jones Journal of Trauma 2015, level 3, what they found was that it's bimal equivalent with direct syndesmotic repair versus direct deltoid repair. It's subjective, functional, and radiographic difference. So basically, if you fix the syndesmosis, they found that, hey, you might not need to fix the deltoid, and it actually is equivalent to each other if you do. I think the Wu study up there shows that in certain populations, even if you fix the syndesmosis with most of the time we're all using flexible fixation at this time, based on everything, that you would have a better outcome if you go and fix the deltoid if you have any question about this. Meta-analysis recently, 2019, level 3 study. Again, I'm just belaboring the point. There's certain subsets of patients in PER and SER4 injuries that you should probably go and fix. And again, why? Go back to Schuberth, showing that the deltoid is likely injured in those certain injuries. And again, why I fix a lot of my syndesmosis, even on isolated fibular fractures, because I just don't want to miss it. And if I can get, based on that Jones study, some help with the deltoid just by doing the syndesmotic repair, and I don't have to do a separate incision immediately, I'm going to do that. And then if it's a high level of injury, I'm going to fix both. Wang et al., 2021, level 3 evidence, systematic review concluded you get better syndesmotic reduction if you fix the deltoid and then fix the syndesmosis. All these studies basically are, in my opinion, going to tell us that we just need better, one, definitions, diagnosis, and then how we did it, and then consistently treating those, and then follow-up. How do we assess this if you're intraoperatively, if you're worried about fixing them or not? Injury 2017 gave us a good study, level 3 comparative diagnosis. They compared CT post-op versus Weber 3 indices, and I'll kind of show this. Basically, if you cannot see on x-rays intraoperatively the Weber 3 indices, they concluded that 7 out of 24 patients will have malreduction, and they concluded that 6 out of 7 of those could be detected by the 3 indices. What are the 3 indices? basically joint symmetric from medial to lateral. You're going to get the dime sign, which we know the fibula is out to length, and then they call it the Mercedes-Benz sign on x-rays. So if you look at those three things, it's symmetric. You have a Mercedes-Benz sign at the level of the syndesmosis, and you have that fibula out to length. You're likely not going to have malreduction, and you know that you're going to have a good assessment of stability. JBJS 2009, excuse me. Again, intraoperative assessment. My partner or former partner likes to do both of these. They do the external rotation and hook test. Again, noting that the deltoid has two different functions, whether you're looking at the superficial or deep. Superficial more valgus, deep more external rotation. So do both. Basically, external rotation increases medial clear space, and what that tells me is that the inferior tib fib ligament and the deltoid is likely gone. So I usually do external rotation. And the hook test basically says that you should maybe just fix the syndesmosis. I'm very thorough on my exam. If there's any question, I'll do a syndesmotic repair. And I won't even question whether I need to stress it or not. If I have question, and again, based on all those studies talking about it, I fixed the syndesmosis on a lot of my isolated fibular fractures just to prevent it from missing a deltoid injury or anterior inferior tib fib injury. But I use the external rotation and valgus stressing to really help me if I should add an internal brace or some equivalent type of suture over the anterior tib fib, or I go medially and fix it with some sort of anchors medially. 2011, level 1 study. Basically, they say do both, hook test, external rotation test. That's how you really intraoperatively assess it. I think this goes back to also if we're taking x-rays and we're using Weber 3 indices, and also you did a scope, you're doing the best of both worlds. You're getting diagnostic through the scope, plus you're doing your stress exam, so you'll know if you should fix something or not.
Again, guys, technique-wise, everybody's going to be doing it a little bit differently. I like to call it a medial brostrum, so I treat this like a medial ankle stabilization type procedure. I use, in my opinion, suture anchors. I am, again, an Arthrex user, so I would use 2 fiber tacks, so small implants, very simple to use and reproducible. There has been some description of dynamic fixation, so using something like an internal brace. Some people do prefer the Artelon, but using something that's more dynamic to also fix that. But I think that's more for deeper deltoid rather than the superficial. And I usually, if I'm doing an ankle fracture or if I'm doing a lateral ankle stabilization with a medial ankle procedure, I'm more going to be doing suture anchors or fiber tacks, something like that, doing a medial brostrum. What does this look like? Usually you're making your incision a little bit more anterior. You're creating that full thickness cuff off of the medial malleolus, placing your 2 anchors, getting that full cuff of tissue, that superficial deltoid, grabbing that, and then when I do this, I really supinate the foot to get really good bone to ligament contact, and then tighten that down as tight as possible. The knotless anchors from Arthrex are really helpful for that. Again, I kind of talked about the dynamic implants, whether it be that internal brace or that Artelon some people like to use. This was a good study, I think back in 2022, really talking about that chronic medial ankle instability drive-through sign that I had just briefly talked about. These guys really talked about a good paper and how to kind of diagnose it, look at it, and then repair the deltoid. So if you're really interested in getting better at this would be a good study to look up. All right, let's go through a case example. This is a PER type injury. In my opinion, this is Weber C. That radiologist has given us a little bit of a flex sign, so we maybe know that there's some type of medial ligamentous injury. Here's a lateral image. You can obviously see a Weber C type injury. Pretty significant injury in my opinion. Here we go. I always do gravity stress. You can see obvious medial clear space widening, very significant in my opinion. This is me fixating him. I did an open procedure here. I might now do a minimally invasive procedure. However, when I'm having any question on whether I'm going to do a AITFL, I always do an open procedure. So my IM nail of the fibula or the fibulac doesn't get in our way, so I can actually do an internal brace for the AITFL. However, on this one, I did a standard repair. How I usually do this, after I do a standard repair, I do an external rotation. If earlier we talked about external rotation, in my opinion, shows more of a deep deltoid type injury. Superficial is that valgus stress. So I did an external rotation. In my opinion, once I see still medial clear space widening, I usually fix the syndesmosis first, going back to that Jones study out of the Journal of Trauma in 2015. It just in my head is the easiest way to do this. So I went and obviously did a couple different stress exams. In my opinion, I felt like I needed to do this. And either way, we went on and did 2 tight ropes. After I did 2 tight ropes, I went back and re-stressed it again because of how bad this instability was. And you can still see there's still valgus stress showing valgus positive on this patient. So then I went back and then did a deltoid repair over top of that and got my fixation. So that's how I usually approach this. This is what it looked like after I did the deltoid repair with 2 suture anchors or fiber tacks, and very stable, very good construct. It looked great and felt great afterwards. This is the lateral. I'll be nitpicky on myself. I'm much more pertinent to do center now for my syndesmosis, so that's something we can talk about in the future. But center technique for syndesmotic repair is very important to me. If you're not going to do center, you always want to aim on the more 1/3 of the distal tibia to get really good anatomic reduction, in my opinion. What does it look like through a scope? I did put a scope in there, so I kind of knew that the deep deltoid was shot based on my intraoperative and arthroscopy diagnosis, which we already kind of knew based on Schubert's study, based on all those studies, that if that medial clear space was that bad, we knew there was likely a deltoid rupture. As I'm learning, as I'm getting better at this, I wanted to make sure, because of how significant this injury was, I wanted to do a more diagnostic scope to make sure there's no osteochondral lesions or anything like that. But I also got a great visualization of the deltoid, so I took some pictures of that, and we can obviously see that that was torn. All right, guys, we kind of did more acute talks. Now we're kind of going into that more chronic. In my opinion, there's kind of, you have to break it down into 2 different types of, is it more ankle instability, or is it more of this chronic flat foot deformity types of things? So more acute, ligamentous, or is it more, hey, I have this chronic flat foot? The acute injury could be a chronic instability, but we repair it acutely, more anatomic than we do a more of a allograft reconstruction. So in my opinion, these are difficult problems, and no one has high level of evidence, so it's really just how you feel about them. I kind of broke it down more of chronic ankle instability, maybe with a little bit of deltoid repair and spring ligament. Then I did more of the allograft reconstructions at the next one. This study really talked about using, in my opinion, ankle valgus and MRI and repairing it with an internal brace, which I think was very good. They did a superficial deltoid repair with an internal brace, and they had really good outcomes. So good functional outcome, high patient satisfaction. So knowing that you can still, if you have some medial deltoid instability, you can repair this using dynamic fixation and get good outcomes. You don't have to jump to a big allograft reconstruction in these study. Near Ideal, another good study, but this was more of for a flat foot, not so much that instability feeling. They reconstructed the deltoid and spring ligament on flatter feet. They had improved pain scores, improved radiographic measures, and they used FDL transfer, plus they reconstructed it with the internal brace. Again, this is for adult flat foots more than just that chronic medial ankle instability. This is the study that I was just talking about previously about the tips and tricks on chronic instability with ankle instability. It's a study out of 2022. They talked about the drive-through spine. They really talked about how to fix it using more of a medial rostrum, but the drive-through spine was a valuable tool in diagnosis in deltoid or medial ankle instability. Rigby et al. Continues to lead the way, in my opinion. This is a 2026 study. The medial drive-through spine is a reliable method to detect deltoid injury. So again, arthroscopy is super important. Don't forget about it. Get good at it. The better you at our arthroscopy, the better clinician you will be, or diagnostic clinician you will be. And they added that if you did a medial deltoid repair, it also contributed to about 23% reduction of that anterior translation. So it contributed to reducing that ATFL instability, and if you repaired laterally and medially, it got back to more native stability than if you just repaired laterally and you left that medial segment. So again, arthroscopy is key. Medial drive-through spine, pay attention to it. Whether you're thinking about chronic ankle instability laterally, don't hesitate to fix medially as well to get the better results for your patients, especially high-level athletes. Continuing to talk about chronic injuries, I'm going in more of that allograft reconstruction. Again, difficult problem with limited quality of studies and evidence. This study in 2019, I believe, level 4 evidence, they reconstructed the tibiocalcaneal navicular ligament. So a flat foot type procedure. 2B to 4A, they said it's indicated based on your own approach. And they improved everything radiographically, improved pain and function, and this is kind of how they used it. They did a portion very similar to this, and then they ultimately switched to this using an allograft. And again, it's hitting on what we kind of talked about anatomy. They're hitting the deep deltoid, they're hitting a spring ligament, so they're getting both the best world. They're hitting everything that we would want to address, in my opinion, to get the best outcomes for your patient. Ellis et al. 2010, they described it using a pronatus longus allograft. They only had 5 patients. They said everything improved radiographically, improved pain and function, and the results held up intermediately. Low level of evidence, in my opinion, with that five patients, but again, it gives us background that there are different ways to reconstruct it. I personally like the next one that I'm going to talk about. This was at a foot and ankle clinic in 2017. It's more of a review article. They really highlighted Meyerson's method of repairing it with an allograft, and I really think this makes a lot of sense to me. If you're just strictly talking about the deltoid, it really gets a spring ligament part of it. It's not exactly doing the spring ligament, but it gets all the medial structures, in my opinion, that I would want to hit, and how I monitored it. And they're using an allograft, and this is kind of how I did my repair as well, and how I shot my allografts when I do these. But a very good paper just to give you another technique to use. And again, reconstruction is difficult. There's no exact way and no high level of evidence how you should repair it. So just be aware there's different ways to do it. Combine this 2019 and 2017 paper, and I think you're going to have really good results, especially if you're concerned about flatter feet. However, I do so much bony work that I don't always just rely on soft tissues. So that's why the spring ligament, I'm probably doing a subtalar joint fusion in some medial column, whether it be a first tarsal metatarsal joint fusion, NC fusion. So I don't always have to reconstruct that spring ligament in my head as much as maybe some others do if they're not as aggressive with fusion procedures. But again, just knowing that there's different ways to reconstruct on these chronic injuries, or in my opinion, the adult-acquired flat foot. Here's just some case examples for me. This was a gentleman, in my opinion, is the ping pong ankle. So he actually had a very high arch with the ankle valgus. So he tipped into ankle valgus because he has a high arch. So the only way he could get to neutral was to collapse. And this is an example of a patient that I did a reconstruction on. So I did a stage reconstruction. I did a flat foot surgery or a fusion procedure to get his foot into a better position. And then I did a total ankle after I did a deltoid repair. And what do I mean by that? You can see his foot. You can see that high calcaneal pitch, but he's actually got a pretty neutral foot here. After I got his foot into a better position, you can see that he's still high arched. You can see how much I changed his arch structure by correcting it, by getting his ankle into a neutral position. Then I used cement and cemented everything in place. And then I came back about 4 to 6 months later and then did an ankle replacement to get rid of his ankle arthritis. But during this procedure, and the stage one, I did allograft reconstruction at that time. And again, I'm a huge subtalar joint NC fusion guy, but this is my typical way of doing it. Here's another example or another case that I've recently done. We did a subtalar joint fusion and an NC fusion, but you can see obviously ankle valgus. We fixed everything, and then even after we fixed it, patient wanted to continue to hip in that ankle valgus, so I did an allograft reconstruction. The patient had, in my opinion, peritalar instability laterally and medially, so I used an allograft and I actually fixated medially and laterally, and this is kind of how I did it. Allograft went in to the medial malleolus, out the anterior tibia. We used the tension slide technique from Arthrex to give us a good button and good fixation. I put an anchor in here. Then I took the other 2 limbs, so I had 2 limbs. I pulled one all the way through the talus, and then I actually did an allograft reconstruction of the lateral ligament, so the ATFL, and anchored that into the fibula. And then I pulled the second limb into the calcaneus and did a button down there as well and anchored that to give me a tibiocalcaneal ligament as well. So different ways to do it, different patients all need different things, but definitely something to be interested in and looking at in the future. And those are just a couple of cases that I've done. All right, I throw this paper in there. Why? Because we've just been talking about adult acquired flat foot and fixing these. Why I think it's important maybe to fix flat feet earlier on than maybe some people do is because if you don't get patients to calm down with an insole and an ankle brace, and they just chronically have to wear an ankle brace to feel better, there's likely some medial ankle issues going on, whether it be posterior tibial tendon, spring ligament, some medial function is bad. So why don't we repair them earlier on so they don't go for the next 20 years and then develop that ankle valgus? And Conti really showed that there's good outcomes if you fix adult acquired flat foot. They basically said it's a dealer's choice. They said using FDL, transfers, medial calcaneal osteotomy, heel cord lengthening, lateral column lengthenings, cotton osteotomies or first tarsometatarsal joint fusions, and spring ligament reconstruction. So a combination of soft tissue and bony work. In my opinion, I'm a fusion guy, so I would probably add subtalar joint fusion in there, and NC fusion in there will also be very good. The things that they talked about is don't do too big of Evans wedge, don't do too big of cotton wedge. Other than that, reconstruction of flat feet is also is acceptable. They say you don't have to do fusions in obese and older patients, but again, in my neck of the woods in the Midwest, fusions always seem to work better for me than just bony work, and I have no problem fusing flexible flat feet. But that's just my opinion. Here's a little example that they gave of their correction after fixing a flat foot. Once again, I put this in there mostly saying that, hey, you can get good outcomes by fixing flat feet, so don't hesitate so you don't develop that chronic medial ankle instability or peritalar instability through the deltoid and spring ligament down the road. All right, guys, we're at the end of the talk here. Really just highlighting that the deltoid and spring ligament are kind of one complex. Don't get over worried about it. Know that the deltoid and the spring ligament are there together. I think they blend together. Even though that the deltoid might be a little bit differently, I always just think of them that they might be working together based on what we know about the anatomy now. Anatomy, we've found out more information, specifically talking about the deltoid. The deep usually has two bands that are there basically 100% of the time. The superficial has basically four bands, and two of them there are about there 100% of the time, or at least 90 to 95% of the time. It has 3D motion. So again, when you're thinking about lateral ankle instability, don't forget about that medial ankle instability. Do some medial drive through sign. Think about that. Think about repairing it to get the best outcomes for your patient. But our anatomy has evolved, helping us treat our patients better. I think there's still controversies that exist on these acute injuries. When, how, and why. For fractures with or without syndesmotic instability, with residual medial clear space widening or valgus tilting. So all these kind of like nuances that make you really confused. In my opinion, you fix the fibula, you stress it. If there's any concern, fix the syndesmosis. It's something that is relatively simple with a tightrope or dynamic fixation, and then you go back and stress it again. And if there's any valgus or continued instability, either add a ITFL repair with an internal brace or add the deltoid in there. And I have really low suspicion on SER 3 or 4 injuries and PER 3 or 4 injuries to fix anything. And my isolated fibula fractures, I'll usually use an IM nail, and then I usually throw a tightrope over top of it 90% of the time, because I don't want my young people or 30-year-olds or 40-year-olds to come back in 35 years and say I got ankle arthritis because I didn't throw a tightrope in there. So I'm very aggressive on that, even if I don't need to be. I'd rather not miss it and fix it, because using center techniques makes it pretty anatomic, and again, it's pretty forgiving if you're using a tightrope. Again, if you're going to repair it, you can use anchors, you can use augmentation, really just kind of dealer's choice. And again, I'll highlight the importance of stability. We found out through those sectioning studies, through arthroscopies, that the syndesmosis and deltoid are connected. So if you have a syndesmotic injury plus a deltoid injury, we know that we're going to likely get malreduction if we don't fix these appropriately. And we know syndesmotic malreduction leads to post-traumatic arthritis. And so just fix them, be diligent about it, whatever way you do it. Controversy is less with the reconstructions, but there's still no high quality evidence. So when, how, why, I think it's really just a dealer's choice. It's a difficult problem with limited quality evidence on the best way to repair it. So just get comfortable in using, whether you're using a semitendinosus, whether you're using a peroneus longus, tibialis anterior, allograft, whatever you like using, and then just kind of read those papers on techniques, how to fix it, and I think you'll get better at it over time. But again, there's no right way to do it. And for me, I just am aggressive on fixing these. The chronic ones, maybe a little less aggressive on flat feet. I usually tell the older patients, hey, I'm going to flex your flat foot. If your ankle kind of continues to tip into valgus, either we're going to have to address it immediately, or like you already have some underlying ankle arthritis, and I'm going to do an ankle replacement on those patients down the road. But that's kind of my thought is that be aggressive on the deltoid, know the anatomy, know arthroscopy really helps figure things out, and know those MRI, stress imaging, and everything above. And if you have any suspicion on it, just fix it, because I think it'll lead to better outcomes, whether it's acute, chronic, or long term. All right, thank you. All right, last and not least, if you have any questions, just reach out to me on that email right there. Follow me on Instagram. Again, disclaimer, I am an Arthrex consultant, so I do mention their products quite often. That's something I use. You guys can use whatever company you want. This is hopefully more educational than it is product placement or product viewing. It's mostly just to hopefully you guys get information from these presentations. All right, guys, have a great night. Thanks.